Welcome to the PharmGenEd webinar on diabetes. Before we begin the session, please note the following. Turn off all cell phones and pagers and program your phone to divert calls to voicemail. This webinar is scheduled for up to 1 hour and will be recorded and posted on our website. Materials for this session are available on this website. We recommend that you register on our website in order to obtain these materials. Please note that after this session, there will also be a Q&A session available for your access as well. At this time, the session will now begin recording and the audience will be muted. There will be a few seconds of silence until the recording begins. Welcome to the PharmGenEd Bridging the Gap Between Science and Practice session for diabetes. Today is September 19th, 2012. This is a re-recording from Wednesday, May 23rd, 2012. This presentation is supported by a grant by the Centers for Disease Control and Prevention. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of the CDC. This content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Today's presentation includes an overview of the PharmGenEd program, a review of the educational content in the diabetes module, contact information, and a survey to assess program materials. There are webinars on additional therapeutic topics available on our website. You may also check there for updates about future webinars. The website will be provided at the end of the presentation. All copyrighted content included within this presentation has been granted permission. No part of this presentation can be reproduced in any form without permission of the rights holder. The Pharmacogenomics education program, Bridging the Gap Between Science and Practice, PharmGenEd, is an evidence-based pharmacogenomics education program designed for pharmacists and physicians, pharmacy and medical students, and other healthcare professionals. The overall objective of the PharmGenEd program is to increase awareness about the validity and utility of pharmacogenomic tests and the potential implications of benefits and harms from the use of the tests. These education modules you see listed are currently available as part of the shared curriculum for faculty. At this time, I would like to introduce Dr. Alex Cho and Dr. Jivan Moaddeb for the diabetes module. Dr. Alex Cho is an assistant professor of medicine with Duke University and a researcher with the Duke Institute for Genome Science and Policy. He received his M.D. from the University of Minnesota in 2001. Dr. Jivan Moaddeb completed her Pharm.D. from the University of North Carolina Eshelman School of Pharmacy. Currently, she is working at Duke University in the Institute for Genome Science and Policy with a focus on pharmacogenomics implementation. At this time, Drs. Cho and Moaddeb will begin presenting.
Thank you for that introduction. Let's start out with the learning objectives for diabetes and pharmacogenomics for this module. We're going to briefly describe the correlation between diabetes and genetic risk, differentiate between classes of drugs used to treat type 2 diabetes for which there are known pharmacogenomic markers and those for which there are not. And finally, practice some potential applications of genomics to patient care. Diabetes affects 25.8 million people in the United States, approximately 8.3% of the population. It is the 6th leading cause of death, and 65% of the deaths are due to heart disease and stroke. Leading cause of blindness, renal failure, and non-traumatic lower extremity amputations. Costs about $174 billion annually, of which $58 billion of the $174 is attributed to drug cost. The prevalence of diabetes is increasing dramatically. As you can see from the year 1980 to current day, approximately, this diagram actually shows all the way up till 2010, and you can just see the exponential growth of patients having diabetes. And it's actually said that people aged 65 to 74 are 11 times that of people younger age to have diabetes. So it's increasing dramatically, and we need to look at it on a different angle to see how we could possibly personalize some medication regimens for patients. So let me give this off to Dr. Cho, and he will start the personalized prevention program.
Thank you, Jivan, and thank you for joining us for this webinar. So let's take the case of a hypothetical patient, Mr. Smith, 46 years of age, male, borderline obese, the BMI on the 30 cutoff, no family history of diabetes, and not from a higher risk group, either ethnically or for other reasons. But because he's heard a lot about diabetes, wants to be screened. What does the evidence tell us to do in this instance? Currently, there is no recommendation for screening before the age of 50, but we know from the pathophysiology of diabetes that the changes that end up harming the microvasculature and the macrovasculature are set in motion long before someone gets a clinical diagnosis of diabetes. And in fact, by that point, the changes are so far gone that it is very difficult for someone to, even by losing weight and exercising, to do that successfully enough to obviate the need for ongoing treatment. So prevention really is an important part of the strategy for managing the diabetes epidemic. A recent addition to our potential armamentarium of information that can tell us about an individual's risk for type 2 diabetes is genetics. And over the last decade, in the aftermath of the sequencing of the human genome and what some consider a sequel to it, the HapMap project, which helped us understand the architecture of the underlying DNA, understand what points of common variation that we as human beings share, at which in many instances can be associated with other observed differences, such as disease prevalence. And so to date, over 40 genetic markers, common genetic markers, which I will distinguish from mutations by the fact that they are common, have been identified that are associated with an increase in type 2 diabetes risk. The other thing that this leads us to understand is that diabetes is a genetically complex disease, that what we're seeing clinically is not necessarily the same genetically and biologically person to person. And we know that intuitively, and you probably know that too from experience. Patients with diabetes come in all sorts of shapes and sizes. So that what we're finding are these sites of common genetic variation that each contribute a small amount to an overall increased risk of diabetes. But if you roll it all up, one could imagine that you could have someone who is at significantly higher risk than another. And so let's talk about the best documented example of this, a variant in the gene TCF7L2, which itself is a transcription factor part of the Wnt signaling pathway that has been implicated as a receptor important for normal glucose metabolism. However, the specific variant that has been associated with this increased risk of type 2 diabetes and replicated in multiple populations around the world is located in a distant non-coding region of the DNA. And actually this jibes with some more recent discoveries which have identified variants in non-coding regions of DNA as being akin to switches that help us turn on and turn off the action of the gene itself. And so our concept of genes and the factors that are involved in their action are evolving as well. The important thing about TCF7L2 is that we have good evidence, prospective evidence over a good length of time that it matters in terms of diabetes risk, but also that if one intervenes like one would to reduce one's risk for diabetes, you can actually see a person with higher genetic risk come down to baseline risk for progression to type 2 diabetes. And this comes from the Diabetes Prevention Program, which was completed around the turn of the century, which had 4 groups initially, but 3 that continued. You had overweight patients who were who were what we call pre-diabetic, meaning they had a fasting sugar not at the threshold where we would declare a diagnosis of diabetes, but higher than normal. And so this would be between 100 and 125 fasting glucose. And so what you can see in the upper left-hand corner is the placebo arm, which was given basically education about preventing diabetes. The higher risk genotype is this homozygous TT genotype, in which case you see that half of those individuals in this education arm proceeded to develop frank diabetes as opposed to a little less than a quarter, or around a quarter of the other genotypes. In the upper right-hand corner, you have the drug treatment arm, where the strategy was to treat with metformin. This is something that the ADA recommends, but there isn't necessarily sufficient trial data that suggests that this makes a difference, but certainly it's plausible to begin treatment for diabetes earlier, and we do this, for example, in hypertension. And then in the lower left-hand corner, you have the lifestyle intervention, which was an intensive, group-based, weekly, supportive intervention to teach people skills for exercising more, eating better, and overall reducing their risk of diabetes. And here you see the two, the high-risk genetic genotype collapsing to the same risk level as the others. So that's a nice demonstration of something that often comes up when you talk about genetic risk testing, and this idea of genetic determinism. Because I have these genes or these genetic changes, does it mean that I'm going to get the disease? And even though having certain genetic changes increases your risk for disease, you still can do things that lowers your risk to that of the average person. And so the other thing important about prevention is that we know that just knowing you're at risk, knowing you're overweight, knowing that eating right and exercising more are keys to reducing one's risk for diabetes, and that diabetes is a terrible disease with all sorts of downstream consequences, isn't enough alone to motivate behavior. What's interesting is that there's been some evidence to suggest that people who are aware of a family history of type 2 diabetes may be more motivated to undertake some changes. This has been from observational data. And an interesting sub-study of something called REVEAL, which I'll get to in the next slide, that suggests that it may increase intention. Having specific genetic risk information may increase intention to undertake positive changes. The other dichotomy, and this might not be surprising to us, is that patients and providers look at the promise of genetic information about their type 2 diabetes risk differently. Whereas a vast majority of patients identify this as potentially motivating, a small minority of providers said that they saw that as well, and that's because we by nature are cynics. But this is a slide summarizing the key finding from that REVEAL study. The study itself was about Alzheimer's and presenting family members of individuals with diagnoses of Alzheimer's with their genetic risk for ApoE4, which has been associated with a strongly increased risk for developing early onset dementia. It also, the ApoE gene has been implicated in cardiac risk. And so what the investigators wanted to see was whether the fact that this information could tell people about more than one condition had any extra power versus the fact that, okay, we did genetic testing for one condition alone, and this is referred to as pleiotropy. And so what they found was that the intentions for positive behaviors with respect to stress, exercise, diet, and vitamins was much higher, significantly higher, in the group who was told that their genetic information told them that they were not only at increased risk for dementia, but also that they were at increased cardiac risk as well. And so that's an interesting insight into the potential power now that sequencing is becoming more commonplace and economical, that the more genetic information we have and the more that it tells us versus looking at things by single conditions, which is how we're used to looking at things, may have some added compelling quality for patients. And so I'm about to tell you about a study that we undertook to see what the observable value or difference of adding genetic risk information to comprehensive risk assessment for type 2 diabetes, what we would see in terms of downstream changes in behavior and impact on clinical outcomes. The test we were looking at was one that included that TCF7L2 marker that I told you about, plus 3 others. I should divulge that in this instance, the company that did the testing, Decode, did give us the testing for free, but we were not funded by the company to do this research. And one nice thing about Decode and some of the other firms that do genetic risk testing is that they are doing it not in a research lab, but in a CLIA-certified laboratory, which means that, according to the feds, this is information that can be used in clinical care. And so the design of our study was this. We basically first asked people up front, and these are individuals, all shapes and sizes, in a waiting area of 2 primary care clinics, whether or not they would be interested in genetic risk testing. We did this because we sensed that there's probably a fundamental difference between those who might not be interested in it for whatever reason and those who would be. And then of those who said that they would be interested, as well as being interested in being in the study, would be randomized to either getting this information up front as part of their upfront counseling about their global risk for diabetes versus those that got counseling on what we call conventional risk factors alone, these being weight, family history, fasting glucose, etc., and with an option of receiving the genetic risk information later at the end of the study so that we could observe, again, what difference did having this information make. So that third group that I told you about who was not interested in genetic risk testing but was still interested in participating in the study, they were followed on the same time points and endpoints. And so what we were looking at primarily was change in insulin resistance and observed weight loss over time, as well as behaviors such as diet and physical activity, and attitudinal factors like risk perception and other psychosocial measures. And I'll show you the risk profile that we used here, where we have by category the different factors that were assessed and some independent assessment of how it contributes to a person's risk for diabetes. We did not strive to present a summary score because numbers often have, are abstract and lack concrete meaning, but by providing people with information about specific things then hopefully makes more concrete and understandable what is actually contributing to their risk of diabetes. So I mentioned fasting glucose, family history, BMI, age, and then for those randomized to receive their genetic risk information up front, what that contribution was. And we tested for 4 genes, so 2 variants per gene, 2 copies in our DNA of each, and then did a simple count of how many higher risk forms a person had, and then turned this box yellow or orange depending on the number. One thing that is important to point out is when we're talking about common variants, you will never have no or zero genetic risk or predisposition for type 2 diabetes. And this is an interesting insight, an important one too, that we're moving away from looking at this information as diagnostic. Like you have this rare mutation, it means that you will develop disease X to helping patients understand that lots of things put you at risk, including your genetics, but this being potentially a sticky way of doing that. And so this study is, the data analysis is ongoing. We've completed enrollment and hope to report results soon. And so let's return to Mr. Smith. So, we oblige him, because as primary care phlebotomists, we like to make our patients happy, and we find out a number of things. That his precise BMI, again, puts him in the high overweight category. He has some other things that we might worry about, such as his blood pressure. He is pre-diabetic. He has a fasting glucose greater than 100, less than 125. In a range where we would consider wanting to do something about that. We also observed that his cholesterol is also elevated and would be elevated were he to develop diabetes to the extent that we would want to lower his LDL below 100. And so, question comes, okay, what next for Mr. Smith? And furthermore, what role might DNA testing have in this care? So I mentioned that he is, not in a category where we would necessarily, spring into action, has some elevated risk, but that if we were to do testing that also corroborated the fact that he were at increased risk, we might suggest a more robust screening regimen to track his diabetes versus like say, okay, good luck, goodbye, I see you in a year. And if we were to find, as we did in his case, that he is at increased, pre-diabetic, more aggressive about suggesting treatment with metformin in line with what the American Diabetes Association recommends. And then with respect to, say, someone who is at baseline risk, we could then fall back to what we might do in a average patient, which is in line with what are the current evidence-based guidelines, meaning that every few years you would screen and that you would not necessarily make any extra effort. The other thing is because there isn't necessarily a firm evidence basis for initiating early treatment with metformin, that becomes more of a, could become more of a discussion with the patient. These are all discussions, but that in some you might be able to present more information with the addition of genetic risk than in others. And so, moving on, Mr. Smith is told that he has this diabetes predisposition. He's urged to make healthy lifestyle changes. One issue that we noted earlier, he does have elevated blood pressure, and so that is something that we want to check immediately. And now back to Jivan to talk about drugs and pharmacogenetic associations.
Thank you. So Mr. Smith is definitely going to be a good patient to look at in the next few slides later. But we're first going to try to talk about some medications commonly used and some guidelines for patients and how we make our decisions on what's the next best thing for a patient if we come up with the conclusion that they're diabetic or pre-diabetic. So this is a chart just basically having some guidelines that are common in practice. American Diabetes Association has certain criteria for fasting glucose and 2 hours after eating and desired A1C for patients. And then American Association of Clinical Endocrinologists, very similar to American Diabetes Association, but I think they're a little more in certain parts a little more conservative and the other parts a little more extreme. So just depends on the preference of the practitioner. So let's go on to the next slide and see some major targeted sites of oral drugs, drug classes available. As you can see, there's lots of regimens now available to patients. And when we're trying to think of what's the best choice for a patient for a medication that we're going to go through, we might look at where the sites activities would be for the medication. So as you can see, there's liver being used. So if a lot of medications are going through the liver, you may not want to choose that one. Or if a patient has stomach issues, you may try to stay away from the gut. And finally, again, the same thing. Diabetes is is decreased beta cell production through the pancreas. So some medications are possibly much better to go through, like for example, through the pancreas, and sulfonylureas are mainstay of medications that are usually used for diabetes. And again, and then there's all the other ones that go through the muscle and fat regimen too for insulin resistance. So you just have to be able to make the decision about what's best for your patient when you're choosing the right oral medication. So as the previous diagram showed, these are the list of current type 2 medications that are orally and injectable available as well. So these are the choices that practitioners have to give to their patients. So, and we will go through each one of these throughout the presentation to talk about which ones have pharmacogenomics information available, or if they're not, even going through pharmacogenomics is not impacting it, and being able to make a better decision for guiding the patient through a better regimen. So first we're going to go with the class of biguanides. Metformin, as you know, is the mainstay of always choosing the medication, first-line medication that most practitioners will choose for patients. It's cheap, it's old, it's been used to the point that everyone knows what to expect with side effects and the drops in the A1C levels that we're always looking for. So currently there is no pharmacogenomics data available for this medication, which means that if it's not been impacting by a gene, then it's actually a really great drug to choose initially for a initial regimen. Again, the major side effects that people can't tolerate are always diarrhea, nausea, vomiting, and flatulence. And as you had seen previously in the diagram with where the mechanism of actions were falling, you did notice that one was in the gut. So if patients have complaints about that, then a change of medication might be warranted. The next class, sulfonylureas, it's usually the add-on for if metformin is not enough, but sometimes it's the initial regimen. It just depends on what the needs of the patient is. It does drop A1C by 1 to 2%, which usually gets people to their desired goals. Adverse events, of course, are hypoglycemia and weight gain upon initiation. This medication, this class of drugs does have pharmacogenomics information available. CYP2C9 and CYP2C9 star 2 and star 3 would signify poor metabolizers. Therefore, an excess drug will remain, and the patient may need a lower dose to be able to reduce the hypoglycemic events. So as you can see in the previous slide, the class had glipizide, glimepiride, and thalidomide. Well, so glipizide and glimepiride are commonly more used, but thalidomide has some data available for pharmacogenomics. So it gives us a better idea to be able to see how it would impact a patient. So there was a study that had 15 healthy volunteers, took a single oral dose of 500 milligrams, and the investigated parameters was the concentration, oral clearance through pharmacogenomic testing. Granted, this is a very small cohort, and occasionally certain ethnicities are emphasized on, and it makes it kind of skewed to make a genuine conclusion about what the best regimen is. But with this data that generated out, it showed that patients that are star 2 have 1.5% increased concentration and 29% greater reduction of oral clearance. And as you can see with star 3, a very similar 1.9-fold increased concentration and 48% greater reduction of oral clearance. Again, this data is not indicative of a large trial, but this gives you a better idea to know that patients will be impacted through having a much higher concentration. So we have to think about that for hypoglycemia and side effects. Glipizide, similarly, very commonly used. they had data generate from a study of 18 healthy Chinese volunteers who were given a single dose of 5 milligrams of glipizide. Investigated parameter was plasma concentration of glipizide over a 36-hour period. Again, the data is very skewed. A specific ethnicity is focused on, but you can see from the slide it shows that star 3 individual has greater under the curve, 95.5%, and a lower glipizide clearance of 55.1% compared to a normal metabolizer, which is the star 1. So again, this makes you think about what's next for the patient. If a patient tests for this, then you may want to think of a different drug or dose lower so the adverse events are prevented. The next set of class of drugs is thiazolidines. Pioglitazone and rosiglitazone, not commonly used as they were before, but still very much in practice. It does drop A1C from 0.5% to 1.5%. Again, with the whole data generating with the DEMA and the heart failure, lots of people have kind of pulled away from it, but it's still being used. And so patients with CYP2C8 star 3 are ultrametabolizers. Therefore, drug clearance is more rapid and potentially a higher dose is required to get therapeutic outcomes. So again, if you have a patient that's having this test performed and they see that they have a higher, they're going to have to take a higher dose, it might warrant for a different medication or letting the patient know that they may be at the max dose that they could be on. Next medication is same same class of drug, rosiglitazone. Individuals with CYP2C8 star 3 genotype significantly lower rosiglitazone area on the curve and are significantly have significantly higher rosiglitazone oral clearance. Therefore, compared to normal metabolizers. Therefore, again, like the previous slide, you have to dose much higher because the patient is getting rid of the drug much faster. Again, this data was generated from a study of 26 healthy volunteers. They were tested to compare CYP2C8 star 2 and star 3 compared to normal metabolizers, and investigative parameter was rosiglitazone area in the curve and clearance. So as you can tell, patients that are testing as ultrametabolizers are going to have a different dose or a different regimen. But again, this data is very skewed because it's very small, not enough power to be able to say this is truly fact. So we'll go to the next class of drugs, alpha-glucosidase inhibitors, usually miglatol and acarbose. Drops A1C not a whole lot, just less than 1%. So it may not be commonly used, but there is no pharmacogenomics information available, so it's not impacting through genomics. Therefore, if you have a patient like on the previous slide with rosiglitazone, this may be a good alternative if you have someone testing as an ultra-metabolizer. But again, side effects are always one of the things that warrant us from trying to use certain medications. This one goes to the gut, so flatulence, diarrhea, and abdominal pain is a major complaint. So it is an add-on therapy, but again, adverse effects does warrant not using it sometimes. The next set of class of drugs is non-sulfurous sucralogogues. This class of drugs is interesting. They have lots of pharmacogenomics information. It drops the A1C to a good value that it is warranted possibly to use. Patients, if they are CYP2C8 star 3, need higher doses due to having lower concentrations of AUC. Again, another marker is the SLCO1B1. If you have a C versus a T, patients will have a higher AUC and respond better to a given dose. And this marker is actually used, interestingly enough, in cholesterol-lowering medications as well. So if you test this marker, you actually get two answers at the same time, which can be helpful if a patient is diabetic, and usually they have an add-on cholesterol medication. So you would know that myopathy, this marker would tell you if they would have increased chance of myopathy, and that could be something else to help you guide a practitioner from choosing the right medication or the best best dose. And the other one marker that this medication is associated with is the KCN J11E23K. It actually gives once you give this medication, it gives an improved therapeutic effect with the medication. So actually you would know that this will work, and you may actually get the 1.5% as opposed to maybe less. But again, adherence and all those are factors too to be able to see if a patient's going to respond the way you want as well. And so, again, in the review with non-sulfurous second and this slide again, we had mentioned that in this class of this medication, again, the A1C drops 1 to 5%. As you noticed in the previous slide, the KCN J11E23K is associated with this medication, as opposed to the other. This medication does not have that marker associated with it, which I think maybe some testing wasn't done when they were doing it to be able to confirm it. So it's only associated with one medication to tell you if they would have the best outcomes. But similarly to the other medication, it marks for the CYP2C9 and CYP2C and SLCO1B1. If you are testing positive for CYP2C9 star 2 and 3, you would need higher doses due to having lower concentrations of AUC. And again, similarly with the SLCO1B1, C greater than T, the patients will have a higher AUC and respond better to a given dose. So we'll move on to the next next class of drugs, the DPP-4 inhibitors, sitagliptin, commonly used, Januvia. Again, adverse effects can warrant for patients not doing well on the medication. It really doesn't drop the A1C too tremendously, so it's usually an add-on therapy. It has a minor impact on metabolism of CYP3A4 and CYP2C8. Again, if it's co-administered with other drugs through the CYP3A4 like a statin, it may increase the other side effects like rhabdomyolysis. All right, and we'll go on to the next class of drugs, the GLP-1 agonists, exenatide and liraglutide, commonly known as Victoza. So basically, Byetta is out on the market. It's been doing very well. Again, it's an injectable. This class is an injectable. People are not that crazy about it, but it doesn't have any pharmacogenomics information. It does lower A1C by less than 1%. Again, the big side effect is hypoglycemia. In addition, that Byetta has been on the market relatively for a good amount of time. They've introduced Bydureon, which is only a once-weekly dose as opposed to Byetta, the daily dose, the twice-daily injectable that you give yourself. So we may be seeing Bydureon used more. Finally, we're to the amylin derivative. Pramlintide reduces A1C by 1%. Again, side effects, nausea, anorexia, vomiting, hypoglycemia. This may be a good medication used if you have a patient that is sort of more of a, I hate to say this as an eater, but it might suppress appetite, and that might be a good medication to consider if you have a patient that complains of that increased appetite. It doesn't have any pharmacogenomics information, so if you have patient testing and you're seeing lots of information coming out about poor metabolizer, ultra metabolizer, then this might be the next best one to be able to get to the A1C goal that you're desiring to get to. And finally, insulin, our last resort, which you know, the only adverse event is hypoglycemia because it's dosed upon people's blood glucose monitoring. It's basically an add-on therapy, or patients have just exhausted oral medications. It's a great medication and no pharmacogenomics information. So again, if you having patients with lots of information generating out, this may be the next best thing. So I'm going to turn this back to Dr. Cho so he can return to Mr. Smith and discuss what our choices could be for him.
Thank you, Jivan. And so getting back to Mr. Smith, 6 months later, like many patients, he misses a follow-up appointment in between, and the only reason he comes to see us is because he has something acutely wrong, a cold, and admits that he found it more difficult than he thought to change lifestyle. He has gained a little more weight. His blood pressure still is elevated, and today his A1C puts him in the range where we would consider him as having diabetes. So we talk about what his options are for glycemic control, and because we're one of these cutting-edge clinics, we're able to offer him multi-marker pharmacogenetic testing. And so Mr. Smith, says, okay, I'll take medications, but I really don't want to give myself shots. And so, what we have here are the ingredients for a potentially very productive discussion about what the patient wants. He's expressed some personal preference, and that really is the role of pharmacogenetic testing. And so we'll get into how we might use this results. But remembering that we're in the moment, we're seeing him today, it might take us 2-3 days, it might take us a week or more to get the pharmacogenetic testing back, and this is a barrier to its use in practice. But today we're going to make some decisions about what to do. So we start with frontline therapy, metformin, not knowing that he has any contraindications to it. And also, since we're offering him this testing, we don't need to pull our punches because we know from Jivan's excellent review that there isn't necessarily pharmacogenetic information that would affect this dosing decision. We're also going to start an ACE inhibitor, lisinopril, for his hypertension. So we get his test results back, and we find that he has a number of these common variants. And so that's good. We file that away for future use. And I'll talk a little bit later when we get to it about, again, this concept of pleiotropy and the idea that if you're able to test once, you can get a lot of information in that single moment in time that can be stored for future use. So we see him again in 6 months. And we would have liked to see him sooner, but cancel, but finally comes back for ongoing follow-up of his diabetes. But that he says that the metformin is bothering his stomach. His A1C today is a little bit better, but we're also noticing, and this may be because of his until recently untreated hypertension, that his creatinine, his kidney function, is a bit impaired to the extent that we would be concerned about discontinuing his metformin. His blood pressure is under better control, but still not quite at goal, which would be less than 140 systolic. So what do we do? Returning to that information that we have, from his prior PGX testing, and to this I'll include the finding that he has the CYP3A4 variant as well, suggests that sulfonylureas, which would be the other first-line choice, usually the companion oral medication for patients with diabetes not yet requiring insulin or other advanced agents, that he would actually be a poor metabolizer of sulfonylureas and possibly at greater risk of hypoglycemia because it's just hanging out but not really doing what it's supposed to. We also learned from this information that repaglinide, may have enhanced effectiveness. And this is an important point because, alluding to one of the issues that we confront with patients frequently, that of varied access to medications and healthcare in general, depending on insurance status, et cetera, that a generic sulfonylurea is cheap, can be gotten $10 for a 90-day supply at any number of pharmacies. But that Repaglinide being branded still, not forever, but at the present time, in many instances may be out of the reach of many patients. And so if you were to try to, need to justify why am I starting him on something that's second or third line, you have this information in hand rather than, the usual trial and error route where everybody, would be put on sulfonylureas next. You'd follow for another 6 months, realize it's not working, and then you'd switch to something else. But in the meantime, you've lost some time, and that does appear to matter in getting diabetes under control and preventing downstream complications. So we start him on Repaglinide, but we find out that we have to go up on it. We do so. He does better. We're adding another agent to improve his blood pressure control. We have to remember to continue to follow that creatinine. But also noticing that he remains above goal for LDL. Remember, before, when he was just pre-diabetic, that LDL of 117, we could let ride. But with diabetes, the evidence suggests that with his increased risk for cardiac events, that our goal should be less than 100. And so we initiate atorvastatin. And again, Jivan alluded to this earlier. Some of the information we have here gives us additional information about how his body might deal with the addition of a statin drug. It may affect its bioavailability, increasing the risk potentially of myopathy, and that it also affects the dosing of an adjunct like Januvia. Should we need to move on to other agents for Mr. Smith, and possibly taking that off the table. And so here you can see how pharmacogenetic information, if stored and used over time, can provide ongoing guidance or nudges to help providers make decisions about basically what are equivalent choices. There is nothing that tells us a priori sulfonylurea versus metformin, or if metformin fails, why not a sulfonylurea? There is nothing that tells us a priori about the next third-line agent to add on, aside from things like insurance coverage, which really don't have anything to do, strictly speaking, with Mr. Smith's own biology and how he'll do with these drugs. And the other important point about that is that this is most economically done in one fell swoop. I mentioned sequencing before. Already, as it is, you can do basically what we call a gene chip for relatively little money, and these are the kinds of things, multi-gene panels that places like Mayo, LabCorp, and others, including pharmacy benefit management companies like Medco, now Express Scripts. Medco actually has pharmacogenetic testing for things like warfarin and tamoxifen in-house. But that doing it at one fell swoop and storing the results may be a more economical way, and then you multiply it by, if you were to do sequencing and the exponential amount of information that you would have. Yes, it is expensive, maybe costing a few $1,000s, about the price of a PET scan or MRI at retail, but that information being good for the lifetime of that patient, potentially. So I'll get off my soapbox now and close with some takeaways. So what did we learn today? We talked about the genetic contribution to type 2 diabetes risk, the discovery that many agents or many variants are associated, each an incremental amount for common forms of risk for type 2 diabetes. That also DNA variants, sometimes the same variants in the case of KCNJ11 E23K. That is both a variant associated with increased risk for type 2 diabetes and also affects the metabolism of some drugs that you might choose to treat diabetes. And that we talked about the possibility that the use of this information can help make what we do more precise and less a trial and error in nature. But that, of course, patient preference is extremely important. And that's the other potential utility of this kind of information. It shows, like a considered explanation of side effects, monitoring of things like creatinine for safety, that when the patient worries about, okay, well, do these medicines interact? Is this the right medicine for me? Do you really know what you're doing? That this is part of that calculus, that this is part of the evidence base we show the patient that we're actually doing what we can, everything that we can, to make sure that the treatment that we're giving them will more likely do them good and not harm. And so that concludes this webinar, and thank you again for your participation. I would like to acknowledge
Thank you, Drs. Cho and Moaddeb, for your presentation. At this time, we will continue with the webinar by highlighting some logistical information. We would like to acknowledge our authors, our reviewers, our editor and editorial staff. The references are listed on these slides for your access and information as well. This information will be posted on our website so that you can go back to it at a later time. On this slide, you will see the contact information for the Train the Trainer program for faculty. You'll notice that we have training for healthcare professional schools, healthcare practitioners. You'll see the the email address for those that have general questions about PharmGenEd. That's pharmacogenomics@ucsd.edu. And we'd like to acknowledge our principal investigator and program director, Dr. Grace Kuo. The individuals listed before you comprise our PharmGenEd team here at UCSD. We'd like to acknowledge these individuals and the CDC for making these slides available. The link listed before you on the slide will take you to our program evaluation survey. We would appreciate your completion of that survey, which allows us to evaluate our program implementation efficacy. And we will now proceed into our question and answer session.
The conference has been unmuted.
The first question that I see from the chat function, and this is to Drs. Cho and Moaddeb, do you currently use pharmacogenomic testing for your patient care?
And so that's a great question. And we're trying to. So I mentioned the study that we're doing in diabetes, and so we're also doing a study of using statin pharmacogenomic testing in a couple of our primary care clinics. I mentioned Vanderbilt before. Vanderbilt is notable for a couple of things. One, they have an excellent electronic medical record. The second thing is that they are one of the recipients of the National Human Genome Research Institute funding to basically develop a biobank and link that to their electronic medical record. And so Mayo is another one of these institutions, and so there's a network that's called Emerge that's looking at this. So what Vanderbilt has done, having been very successful at getting patients, so this is any patient they see, to join their biobank, give a biological sample, have it genotyped, etc., that given their electronic medical record, they're able to, through their computerized physician order entry, provide alerts now if someone tests and has both copies of that marker associated with increased risk for statin myopathy. So if a provider is about to order a statin and they pick simvastatin, which has the highest risk, then they get an alert saying that, did you know your patient carries these genetic markers, puts them at increased risk, would you consider prescribing something else or at a lower dose, as an example.
We have an additional couple of questions. The first is, The speaker discussed a C to T change and stated that C greater than T, meaning the C allele was better. My understanding is the T is the mutation and the patient will respond better with the T allele than the C wild type allele. Can you please clarify?
Yes, and so maybe I'll just zip back to, so that, and this is where the language around how genetics has usually been talked about is also confusing, because mutations by definition are rare. And so in genetics parlance, they talk about major alleles and minor alleles. And this is, but then the action of these alleles can be up or down, right? You can have a major allele that increases your risk for something like type 2 diabetes, for instance. And here we have an example. If you look at CDKN2A, you'll see that the risk associated with that particular genotype is actually less than 1. And so here they're testing for an allele that actually is associated with lower risk. And so, so in the case of TCF7L2, if you carry the C 1 or 2, then that's the wild type, meaning that it is both the more common allele and it's also the one associated with lower risk for type 2 diabetes. The T allele is the one associated with higher risk. If you carry 2 copies, TT, that's the cohort that showed 50% progression to type 2 diabetes after 3 to 4 years in that placebo arm.
And the next question, what would you suggest for clinicians to use as decision support once they receive a genomic analysis? Do many practicing clinicians know how to interpret and use a CYP2D6 variant or 2C19 variant?
And the answer to that is no. And actually Jivan here is part of a groundbreaking study where, and you know this, that the role of pharmacists in clinical care is evolving. Here, the director of our ambulatory pharmacy is very excited about breaking into primary care, where the same kind of resource that's available when, I'm on service in the hospital can be made available in the clinic as well. And so this is an evolving area where I would not be surprised if, like with, pharmacodynamics, et cetera, you become the content expert, and that whether it's through an EMR or whether it's because you have lists of meds the patients are on, or as you're doing med reconciliation with patients, you notice things, the opportunities where pharmacogenomics can inform. I'm going to stop short of making any recommendations for testing platforms because there are some that are commercially available, but not necessarily with that level of decision support that you mentioned. I will highlight one resource called Pharm.GKB that is also funded this time by NIGMS, the National Institute for General Medical Sciences, which is collecting all of the information that Jivan talked about, not just for this, but for multiple conditions, and organizing it in such a way that it can become a reference. However, it's heavy on the science side and not really clinically oriented. So that's really the last frontier and something that I see pharmacists playing a critical role.
And we have an additional question. In the case of CDKN2A, AA is more or less risky for diabetes in compared to AG?
Yeah, so then that would be correct. Because what they're showing is that AG, so genotype is associated with lower risk, and so then the AA. And then you can see, like I was saying with TCF7L2, the TT associated with that increased odds of 1.54. But
we have a question regarding the resource, the Pharm.GKB, that is available on our PharmGenEd website here at UCSD, and the information can be emailed out as well.
Super. The one thing that I would say about this, for example, when I get a blood test and I'm looking at someone's hemoglobin, right, I know what the numbers mean. I mean, I know that 7 is bad and that above 10 is okay. but I don't know anything really about the test or, actually like about hemoglobin. I just know that the number has a meaning. And that this is one of those areas where, again, that right now it's dominated by the science of genetics. What does that base pair mean? What does it do? Whereas, as we've seen in the pharmacogenomic pilot that I mentioned around statin myopathy, that all the practicing clinician really can use is like, do they have it, do they not? And then if they have it, what do I do? And in that case, maybe avoid simvastatin and use lower doses. Think about like pravastatin, rosuvastatin, because those have lower risk for statin myopathy. And then the practicing clinician says, good, as long as it comes from a trusted source, like a pharmacist like Jivan or one of you. And so this is an evolution, and where the practical, how we use this information practically, how we create trusted sources for the decision making is going to be very important, and where people like Grace are really at the forefront.
Are there any additional questions from the audience? You can ask those over the audio feature or using chat. Okay, and an additional question. With the CDKN2A genotype in the table, the heterozygous type is noted. It's common notation to write the wild type allele first and the variant second. Is that correct?
Yeah, I mean, so Sean, you're a closet geneticist, aren't you? And so, normally, yes. I mean, so we can get into, just like with Mendelian genetics, there's a language of dominant variants and recessive variants. Like, so, for example, in the case of TCF7L2, it behaves in almost a recessive type fashion, meaning that, it's the group that has 2 copies of the higher risk allele that then translates into the higher risk of progression to type 2 diabetes. That was not observed in the heterozygous condition. So in the case of this this variant, they found that heterozygotes were the ones that you only needed 1 copy to then, I guess in this case, receive the benefit of the lower risk. The other thing that I would say, again, these are basically epidemiological observations. And so the biology for them isn't necessarily known, but obviously is a focus of evolving research. And so sequencing really promises to tell us a lot more about the true nature of these things. And Sean, I saw your follow-up. So that, where you see them associated with increased risk, so that would be the higher risk form. The reason I'm not going to use wild type is because remember what I said about major versus minor. Clinically, what's important to me is what is associated with increased risk. I don't necessarily care whether more people in the population carry it or don't. So in the case of PPAR gamma, you can see that the population frequency is actually 81%, so that most people carry a variant that is associated with increased risk for type 2 diabetes. This is one of the reasons why almost no one in our sample, actually no one in our sample had 0 higher risk variants, because there's a high likelihood that they would have, one, if not both, of the higher risk PPAR gammas. And so I'm sorry. So Sean's follow-up question was, in the table that we're looking at, how do we know which is wild type and which is quote-unquote mutation? And so I'm just explaining that what's associated, that maybe a better way to look at that is higher risk versus lower risk, and that you should be able to infer from what's presented. But this, again, is one of those challenges with respect to how you use this clinically, where an expert like you, Sean, can look at this and know that, okay, so in this case, C is the higher risk genotype. When I get that testing report, I know what it means, and so when I give the advice to the clinician, or I create the decision rule that then will inform the alert that a physician might receive, that will all inform that. But then for the practicing clinician, it really is not realistic to expect them to understand it at this level. So that if they get a report and all it says is like, okay, CG, then you're going to just get blank stares, and that paper is probably going in the garbage.
Any additional questions from our attendees? If there are no additional questions, we would like to thank all attendees and Drs. Cho and Moaddeb for the presentation. If questions arise in the future, please contact us at pharmacogenomics@ucsd.edu or visit our website at pharmacogenomics.ucsd.edu. Thank you.
Thank you.
Thank you. Please stand by.